let's think through this scenario and really run scenarios rather than just saying, oh no, okay, let's delete that. Because I think that's when we're going to have hospitals that aren't going to function the way they're needed to function in the future, if we don't truly look at the care aspect as part of every design project that we do.
Welcome to SSR On Air. I'm Mike Rogers, your host for this monthly podcast brought to you by Smith Seckman Reed. Tune in as I interview leaders, colleagues, and clients about what is going on internally at SSR and in the larger engineering community. Okay, so we'll get started with our all-star panel here today. So we're going to do a little discussion here. This is for May, Nurses Month. And appreciate it. We've got three folks with us today, a couple of Debbies and a Robert, and so I think both the Debbies, you guys have been on a podcast before, so appreciate you guys returning and talking about things. Robert, it'll be your first time, so
my first time.
Yeah.
Long time listener, first time caller.
There you go. Well, I appreciate it. And I wanted to first say thanks for you guys being nurses, joining that. I think there's 4.5 million nurses in the U.S., which we could always use more. But appreciate you guys doing that, choosing that career.
It's very fulfilling.
Good. Well, and that's kind of, I guess, one of my first questions is what led you into that career to start with, and maybe a brief trail of how you got here to SSR, maybe. And why don't we start with you, Debbie, first.
Well, I grew up in a medical family, so medicine was talked about and an option as, growing up, going to college. So actually, as a child, I wanted to be a nurse or an interior designer. So,
those are similar.
Yeah, similar. Back then, though, there was no similarity and no dual path. So I went into nursing, and it was just logical because of my family history of being in medical. So I was a nurse for probably 20 years, and I worked in ICU and started off at the VA, and then started doing some home health type of work, and I decided, I think I want to try something different. I want to go back to interior design school. So I went back to interior design school thinking I was leaving nursing, and they asked us to do a healthcare design project, and I was like, oh, this should be easy because I'm just going to ask the nurses how they want their hospital design, and there was no input from nurses. So fast forward, I decided that I felt called to really be that voice in nursing for healthcare design, and started the Nursing Institute for Healthcare Design, and that was about 20 years ago, and I've been at SSR about 15 years, and I came to SSR because Scott Johnson wanted me to be on a panel, and I invited them on a panel as well. You did have a nurse at that time, Joanne Chappell, and I got to know Scott, and after our little panel discussion, he asked if I wanted to come to SSR. So I decided to do that, and I've been here for 15 years in the technology planning division, and I kind of call myself an interpreter for the designers, the architects, the engineers, the technology, to translate the design of the built environment to nursing and back and forth. So that's how I got to SSR.
Awesome. Great. Robert, how about you?
Well, when I was a kid, I wanted to be a pharmacist. That was my dream job. That was like most dreams. Nothing really came of it. But when I was traveling as a young 20-year-old, I managed to travel with a bunch of nurses who seemed to have a pretty good job. They were able to travel around the world, get work anywhere. They had money to spend. And I thought that might be a good area to pursue. So when I got back to Australia a couple of years later, I started nursing and loved it, and worked my way up. And I ended up being manager of some ORs in a big hospital in Sydney. And then as I got further away from the patient, I got a little dissatisfied with the people management, but I left the nursing and went into medical device sales and did that with a large German company for about 20 years. And I had a very good friend called Debbie Heitzman, who was running her own company of medical equipment planning, who said to me 1,000 times, "You should come and work with us." And I said, "Oh God, no, I couldn't do that." Anyway, she eventually got me. And it was a great move because I'm able to take my nursing skills, my clinical knowledge and understanding, couple that with the stuff I learned when I was selling and marketing equipment devices, and it all comes together as a planner that I understand the clinical needs. I'm very big on workflow and ergonomics, and I think that having the clinical background is a huge advantage for an equipment planner because nurses are kind of suspicious people as well. And when I say, well, I was a nurse and I did this, they immediately, like the walls fall down and say, oh, he understands what we need to do. And I love that because that actually feels like I'm being appreciated for what I can offer. And in the planning, it's just really gratifying to put together a list of equipment so that people are able to achieve what they want clinically. And ultimately, it's having a great patient outcome. So it's in my own fantasy land, I'm taking everything that I learned and using it to get that ultimate result. So I'm very happy.
Sounds great. Sounds great. Debbie, how about you?
Well, I wish I had a more exciting story as to why I decided to be a nurse. My two best friends and I really had no idea what we wanted to do. We had sort of tossed around various ideas, but one of our sisters was a nurse. And so we thought, oh, she's got a good life. She seems to be having fun. So we decided to apply for nursing, and we, of course, decided that was, our career path. And we followed that for many years. We, after finishing my general nurse training, I went and did my midwifery training and then decided that was not the area that I was going to focus in, and went into the operating room and stayed in the operating room for probably 15 years, and then was part of the educational faculty at a large teaching hospital in Melbourne, Australia. And from that, we were teaching surgeons and nurses room layouts for new surgical techniques. And our professor of surgery said, "You seem to be enjoying this," and gave me $500 to start a company, which was a consulting firm. And then fast forward 18 years later, oh, actually, no, it's more than that. It was probably 25 years later, SSR came knocking, and we decided that, yes, we were going to join forces. And so I've now been at SSR for 4 years. So a very non-auspicious start, but it's been a great career. We've traveled the world, we've worked around the world, and it has been just a wonderful experience. And like Robert, our clients have greatly appreciated our clinical knowledge and understanding when it comes to our medical equipment planning, and we feel that we've been a great asset to their team with that inside knowledge of what their needs really are.
So good background story. So a little bit of connection between Debbie and Robert. You guys are connected in some way. So what's the background there? How do you guys know each other?
Do you want to take it?
Yes. One of the best friends that I had talked about actually worked with Karl Storz along with Robert. And so we had met through a mutual friend and had known each other for many years. It then turned out that when my husband and I got married and he moved to Australia from the United States, he actually started working at the same company. And so then Randy, my husband, and Robert became colleagues in Australia, and I was doing medical equipment planning unrelated to what they were doing. And so fast forward, we moved to the United States in 2000, and Robert would come and spend most vacations with us here. So our friendship continued across the vast distance. And then I was continually saying, why don't you come and work with us? We're really good people. And I got him on a very weak moment, and he agreed. And so when Robert came aboard, he actually was running our office in Australia. And then we were having some issues with our Canadian office. And so he very kindly moved to Canada and lived in Toronto for 5 years, running our Canadian operation, which was just prior to when we were starting our negotiations with SSR.
Oh, very good. Very good. So let me ask each of you, with the Nurses Month in mind, what organizations or what things do you guys get involved with? I mean, outside of doing what you're doing at SSR, what else are you guys doing individually?
Well, my husband's a nurse, so and I think that's another connection. So with the work that he is still involved in, we're both members of the American Operating Room Nurses Association. So it's the educational side of that we use in our everyday practice, making sure we're keeping up with current trends. But I think outside of working, all of our friends are nurses as well. So it's a very incestuous grouping of friends, because you're always talking about what's happening in nursing, and you're hearing the gossips from places where you may have worked previously and what's happening. And what we're hearing now, which is really very sad, is the incredible nursing shortage. And so what we're hoping is not going to be diminishing patient care, but I think that's going to be the end result. And I think that's a concern for all nurses today, is that the nursing field has changed so much. We've implemented so many nursing assistant type roles that the true role of the nurse, when we all did our education, is being eroded. And the nurse, if nobody understands this, is actually the advocate for the patient. So if you erode the role of the nurse, the patient is always going to be the one who will lose out in the end, and that's not what our goals are or why we did nursing.
Yeah, very good. Robert, how about you?
Well, much the same as what Debbie said in terms of organization membership, but I also maintain friendships with my colleagues from my previous roles. I had to get some documents together for an immigration thing recently about my employment, and I was kind of a little shocked, but really happy that I was able to call people I worked with more than 20 years ago and say, I need this document. Can you fill this out? And they said, sure, that's no problem. And that was several jobs ago. But I find in healthcare, it's a really extensive network. And I constantly run into people I know in the oddest places, and we're always talking and keeping up. We work a lot with vendors, because being vendor neutral with our services, we need to keep abreast of everything that's happening. And because I have friends who are nurses, friends who are doctors, friends who are in device sales, friends who are in development of instruments, it's interesting for me to be able to just try and stay abreast of all of the changes and things. And it's also really interesting, as Debbie said, looking at how the roles have evolved and changed, maybe not always to the better, from when I was doing scrubbing the walls of the pan room with the nuns wiping down the walls saying, do it again, because I still see a mark. Nurses don't do that sort of thing anymore, but it's kind of interesting to see. Back in those days, we had excellent patient care. We did very, very good patient care, because we were told that's all we're good for, so don't try and think you're better than that. And to see that as technology changed, and then the role of the nurse feels like it's getting further away from the patient to me. And I think that's sad, because as Debbie said, nurses are the advocates for the patients. And having gone through my parents, who recently, in the past couple of years, both have passed, and seeing them in the hospital, walking in and turning into old Nurse Robert and taking over the care, because I wasn't seeing that hands-on personal care that I was used to giving. So it's kind of, it's interesting to try and keep up with what's happening and be able to apply that into how we deliver our information. And first, Debbie was talking about earlier about we're talking to architects, we're talking to construction people, we're talking to finance people, we're talking to clinicians, being able to interpret how to give the information to them so they're going to get the best result from our services. I talk to the more junior people and say, always put yourself in our client's shoes. Imagine that you're employing me. What do you expect from me to help you get this done? I find that's a kind of empathetic, great way to think about what I should be doing to make my service valuable and useful.
Yeah, that's good. That's good. It's concerning. I mean, I think you guys are close to it and you feel it more than us, that they don't spend time with that. So it's good to get that perspective.
And being a nurse for almost 40 years, you've seen a lot change. I agree with Robert that, the nurses are the patient advocate. And a lot of times, now we as family members, we feel like we have to be present because we don't know that they're going to get that grade of care. So my view right now is that healthcare is really broken. We've kind of gotten away from that standard of care and that standard of practice just from a medical system in general throughout the U.S. And I think, it's a lot about money. It's a lot about just insurance claims and that sort of thing. And I think it's very hard for people to navigate the healthcare system right now, which is frustrating. And so I feel like one thing that I'm involved with right now is really trying to figure out how to fix this from really a larger ecosystem level. And I'm working with the American Nurses Association. I work with Sigma Theta Tau and other kind of leadership healthcare organizations that are in nursing to try to innovate and create and shift how healthcare is done today, looking at nurse-driven models and how nurses in the community, nurse practitioners, can have clinics that really seem to meet patient care at that really human level, and kind of developing a different healthcare model. One of the other ways that I'm involved in it, as far as nursing, is when I started the Nursing Institute for Healthcare Design, we started really focusing on evidence-based design, which is really how to design an environment that improves care and improves outcomes. And so because of that interest and because of the research that's involved, I've become a co-editor of the Health Environments and Research Design Journal. So I see a lot of the research being done around the country and try to advocate for that evidence-based design and really creating a platform for those best case scenarios, best practices to be really advocate for in the industry. So that's one way. And then we've started the Nursing Institute for Healthcare Design Foundation, which is a sister organization to NIHD that really promotes nurses doing research in their practice and identifying in their practice in the hospitals what is working, what are they doing innovatively to help improve and change outcomes. So trying to advocate for nurses to be more innovative, to step up into leadership, to create new models of care that are ways to fix the healthcare system we have now.
Do you find that the nurses have the freedom, I guess, to do that type of, introspective look? And, because I know there's a lot of, guidelines like you talked about. There's things that they have to deal with from an insurance standpoint, a profitability standpoint, all these pressures that are on them. Do you find they've had that freedom?
No. And a lot of it is because because we're in a medical model, so a lot of it is driven by the physicians. It's not really as much a collaborative model as we would like to see. I think that some of that's changing and really highlighting COVID and the things that happened in COVID have really brought the clinical perspective and clinical voice forward, but I think there are still challenges. I think a lot of it is the culture of the leadership within each institution. I've seen a lot of hospitals where they have a shared governance model, which nurses really have a voice and they can bring their ideas forward, and there's a ladder that really elevates those ideas, and if everyone accepts it and it makes sense and it's really evidence-based, then they will implement that, and nurses do have a voice there. Other health systems, it's all about staffing, it's all about profitability, and so both of you see that every day as well, and it's mostly nurses are just filling a role of a patient care ratio.
Correct.
I think that sorry, Deb. I'll go. I think that one of the sort of milestones for me was making that understanding that healthcare is actually a financial venture these days. And as much as we want to think, no, it's all about the patient, and of course it is, but through the lens of the financial workings. And Debbie Heitzman and I have had the benefit of working in public health systems and private health systems. And it's interesting the different focus and the way they work. And that brought a lot of change to about the delivery of healthcare. And I think that interesting about the growth in technology and telemedicine and things, and there's a current trend to sort of downsize facilities because we're doing this virtual doctor visits and such. But the reality is the patients that the growing, aging patient population are the ones that are the most technologically challenged. And they're the people that really crave that human interaction. So it may be very modern and clean and lovely to say, I just call up on my laptop and do that consult. But there are certain things where you need to actually touch a person and examine them. And the most vulnerable people are the ones who are in the greatest need of care, especially in chronic conditions. So it's a really interesting dichotomy to me. And I was in a discussion recently about, well, we're going to downsize the number of exam rooms and share these offices because people are doing telehealth. I said, but look at your patient demographics and who are these people and are they going to be receptive to that? Because you save time and money here, but then you have to increase, you've got to send people out into the community and teach people how to use technology, provide the technology in the home. So I find that really interesting because I always go back to, you have to put hands on a patient to give care. I'm old fashioned like that, but that's the reality.
It is. And I think also we know when our parents were aging that it was impossible even just for us communicating with them from another country, and trying to get my mother to learn how to use an iPad was probably the most frustrating part of my life. But that many people don't even have internet access. Why would they? They don't have a laptop. They don't have any other devices. And many times they don't have a smartphone. They still have their phone that is on the counter in the kitchen. And so I don't think that people are probably wishing and hoping that this will happen. But in the meantime, there's still going to be a lack of patient care by trying just to do video visits. It's just not.
Yeah.
It's not there yet.
You just need to consider the needs of all the various demographics. The young people don't want to go and see someone. Certain people culturally don't trust healthcare professionals, so that they don't have to face, that's more comfortable for them. But that's only one segment of the market. So it's kind of it's an interesting exercise to try and address all of the needs within budget, within time, in the footprint, and have that successful outcome, clinical outcome.
Yeah.
You can see I kind of worry about it.
Yeah, I agree. And I just one thing to add to that is, one of the foundational tenets of nursing is caring and touching, and that's not really valued today like it was. And that's one of the reasons why I went into nursing, is to really provide that caring spirit, and that whether you're helping a patient up and you're touching them, you're putting your arms around them, you're caring for them. That's one of the things that I loved about nursing, is really being able to be in touch with your patient and really care deeply for your patient and see them improve. And you really kind of became part of their family, because you sometimes families, we keep in touch after the patients would be discharged. So I think that's not valued as much now. And also with the technology planning and the telehealth and the virtual nursing, I think that's a way to improve the nurse-patient ratio from a administrative standpoint. But from a nursing standpoint, and a workflow, how does the nurse now translate that into, I'm taking care of my patient, but someone else is looking on and taking care too. So now what is my role? So I think it's changing, and I think we're at almost a crossroads where I think eventually it's going to go back to that hands-on caring.
I agree.
Because that's what people need.
I think that will be a differentiator, that we can offer this level of care that you don't get somewhere else. And, that would be the smart thing to do if you're looking at making money, because then you can charge more, whatever, cynical. But, I think that's a way of getting back to it. It was like when minimal access surgery suddenly exploded, and suddenly everyone wanted to do everything through keyhole and a telescope. What I saw, the biggest downside of that was, as in the OR, as I was the scrub nurse, and I'd be holding a retractor for the surgeon, and you're really watching and monitoring and seeing what you're doing. Once it's on a screen, I would walk into rooms and see people standing talking to the circulating nurse, not even looking at the screen, because they didn't feel they were part of it. So that was where technology really came right between the patient and the caregiver. And so everything is like, it gives and takes, right? You just have to really focus on not losing the end goal. And
Correct.
And it's clearly, it's something that I really feel strongly about, and I don't really know the answer, but that's an interesting thing to me.
And I think in our role that we have as technology and medical equipment planning, we are often asked by the client and by the design team to participate in design meetings. And when they're wanting to remove rooms that they think that they don't need, based on some research that's been done, but the reality of the situation is they are going to need it. Trying to be that voice of reason, just try and help them with real life advice of, let's think through this scenario and really run scenarios, rather than just saying, oh no, okay, let's delete that. Because I think that's when we're going to have hospitals that aren't going to function the way they're needed to function in the future, if we don't truly look at the care aspect as part of every design project that we do.
And that's something that I like to use as a differentiator against our competitors, is because people are very quick to tell you how terrible the equipment planner was on a job. So if I do, like Debbie said, you'll hear me, you get to read the Robert code. I'll say, it's really interesting. Tell me how you're going to use that, which is my way of saying, no, that's not right. That's not going to work. But I'd like to try and help them come around and realize it. And I would like to think that people say SSR did a great job because they gave us a really ergonomic, functional design. And that's where I really rely strongly on my nursing background and my clinical experience, because I know if I'm going to do this procedure, where am I going to stand? Where do I need these pieces of equipment to be placed to make it easy? I talk about, what is that thing I say? Sneaker something. How many steps between that room and that room? Do you really want to be making that trip 20 times in a shift? Think about that. Mm-hmm. Move the room there, and you're saving that time and energy. So that I'm just used to being able to sell our differentiating points to why we're the preferred provider of these services. And that's where I think the nursing background is a huge advantage.
Well, it is. I mean, I think, when I think about what you guys can add to the conversation as opposed to just, the technical side of it, like you said, the equipment or the technology behind it, the life experience that is added on by the things that you've been through and your perspective, it's invaluable. I mean, in my mind, and I tell regular engineers this all the time, is that when you're sitting at the table, you have life experiences, you have things that don't be afraid to share those things. They're not hiring you to sit there and only answer a mechanical question, and if you're going to be that advisor, that real contributor to it, don't be afraid of stepping up and stepping out of your boundaries a little bit, right?
We also, in a lot of RFPs lately, we have seen the client asking, we want to hear about what hasn't worked in the past as well, because we have got, with the number of projects that we have done around the world, we have some very good experience of things that sound great on paper, but then when they're implemented just don't work. And so, being able to really present all of the facts to the client is a huge advantage of not just all the positive, but also the negative of, sometimes, we've suggested items that sounded great and there've been papers written on it, and then you actually try to implement it and it doesn't work. So I think those real life experiences of sharing those with our clients is a great advantage of our team, because we have people from so many different backgrounds, so many different countries. We have a lot to bring to the table.
I think it's a great lens to look at, from a design perspective, because one example is, in technology, all these people are bringing all these new technologies into the patient room, and they all have display panels, that are required for that particular device. And so at one of our last mock-ups, I said, let's print off every single display panel that's required with all this technology and just hang it on a wall somewhere. And so we hung up probably 10 pieces of paper that were all the displays. And I said, now how is a nurse going to watch all this from outside the room at the desk unless, and they're not going to be walking back and forth. So how is this all going to work together? And I think that's part of the lens that we bring is, sure, all this stuff is great. These people are working in silos, bringing technology or designing a room or engineering a room. But then we're standing back and saying, how is this all going to work together? It's not going to function properly for the end user of the room, who's generally the nurse, who's going in and out of that room.
So, and Debbie, even something as basic as, that's all of the equipment you want in there. Where is the nurse? Where is the patient? Because we can't fit them in with all this equipment. So you're going to need a bigger room.
Yes. And also knowing nurses come from 5 foot tall to 6 feet tall and not mounting items on the walls that just are not at a height that's relevant. And as you were saying, seeing things through the window, not everybody has the same visual acuity to be able to see the face of the monitor and the size of the font the same way as each other. So we need to make sure that all of those are tested. And I think that's why the value of true mock-up rooms is so important, because it allows the clinical users to touch and feel what's going to be in the room, rather than trying to look at a 2D or even a 3D fly-through. It's just still not the same of physically being in the space, seeing the equipment around you and saying, this isn't going to work prior to anything being built. I think that's a key advantage when we do complete mock-ups.
Thanks for tuning in to part 1 of our podcast for Nurses Month. Stay tuned for part 2 later this month. Thanks for joining us for this episode of SSR On Air. We hope you enjoyed it. Be sure to like and subscribe wherever you get your podcast. You can also connect with us on social media. Links to everything can be found in the show's notes. Take care, everyone. See you next time.